Okay, imagine this for a second. You've got a patient, right? Someone who's been bounced around for years, specialist after specialist, just looking for answers. They've got these really vague symptoms that keep shifting. Joint pain that flares up then fades, stomach problems messing with their life, maybe even this, like brain fog creeping in.
Yeah.
They've had all the tests, seen everyone gastro, neuro, rumen, but still nothing. No clear diagnosis. It's incredibly frustrating, debilitating, really, for everyone involved. That whole scenario, that feeling of being totally lost in a diagnostic maze, that sets us up perfectly for our deep dive today. We are diving deep into an illness that is the absolute embodiment of that challenge, that multisystemic, hard-to-pin-down foe, Whipple's disease. Our mission here, as we unpack all this, is to really master it. We want you, the listener, to get this like the absolute pros do, to recognize the subtle signs, the big flashing lights. We're going to unpack Tropheryma whipplei, that's the elusive bug behind it all. We'll get into its crazy range of symptoms, trace the honestly fascinating history of its discovery over a century, explore the key tools that finally let us see it, and look at how treatments are evolving, how they're actually saving lives now. We really want to get why it's missed so often and just how critical getting that diagnosis right and early really is.
It really is striking, Whipple's disease just perfectly showcases that incredibly complex and often really deceptive dance between a pathogen and the human body. Like you said, George Whipple first described it way back in 1907. And at its core, it's a chronic infection caused by Tropheryma whipplei. But the biggest hurdle right from the start and even now is the time lag. Years, often many, many years, can go by between the first vague symptom and actually getting the right diagnosis.
Wow.
Yeah, and that delay. It happens because, one, it's rare, but maybe more importantly, its symptoms are such incredible mimics. They look like so many other more common conditions, which means you absolutely need specific, non-routine diagnostic tests that aren't usually top of mind for doctors initially.
And it took a while just to confirm it was an infection, right? There was this idea, this hypothesis, but proving it, that was a different story. Can you walk us through that? How did we finally nail the culprit?
Absolutely. That suspicion, the idea it was infectious, it was initially supported by a couple of really key observations. So back in the 1950s, doctors started noticing patients getting better, sometimes dramatically better, when they were given antibiotics.
Ah, the classic clue, if antibiotics work.
Exactly. It points towards bacteria. That was a huge clue. Then jump to the 1960s, electron microscopy comes along, this amazing new tool to see tiny things. And researchers could literally see these little rod-shaped bacteria, bacilli, right there in biopsy samples from the small bowel.
So visual confirmation, getting closer.
Getting much closer, definitely strong indicators, but still not that absolute slam-dunk proof.
So the smoking gun was still missing. When did that aha moment finally hit?
Okay, so here's where it gets really interesting. The definitive proof, the moment everyone went, yes, that's it, didn't happen until 1991.
Wow, decades later.
Decades. It was a landmark moment, really. It came through PCR polymerase chain reaction, that molecular technique. Scientists managed to amplify and then sequence a specific piece of bacterial DNA, a part of the 16S RNA gene, directly from duodenal tissue from patients. That molecular fingerprint finally isolated and identified Tropheryma whipplei, no doubt about it. It was like finding the suspect's DNA at the crime scene.
So PCR was the absolute game changer. It just completely reshaped how we understood Whipple's.
Precisely. Totally changed the game. After nailing down the genetic ID, researchers could finally successfully grow T. whipplei in the lab, which had been incredibly difficult before. And growing it allowed them to sequence its entire genome. That opened the door to developing even better, more sensitive diagnostic tests. So PCR didn't just give us a better test, like you said, it fundamentally broadened our whole understanding. How it spreads, its epidemiology, and the whole spectrum of diseases it causes. It took it from being this rare gut thing to being understood as a widespread, multi-systemic infection that could pop up almost anywhere. Much bigger picture.
Okay, let's talk more about this elusive pathogen itself. Tropheryma whipplei. What are its basic characteristics? What makes it tick? Or maybe not tick so fast?
Right. So T. whipplei is what we call a weakly staining gram-positive bacillus. That just describes its shape and how it looks under certain stains. But its biology is where it gets really fascinating, and it directly relates to the disease. Sequencing its genome showed it has a tiny chromosome, less than 1 megabase, which is, well, minuscule for bacteria. And crucially, a lot of its essential machinery, its biosynthetic pathways for making things it needs, they're either missing or incomplete.
Meaning
Meaning it's highly dependent on its host. It's likely either an obligate intracellular pathogen has to live inside our cells, or it needs a very specific nutrient-rich environment outside cells. It can't make everything itself. And maybe the most striking thing, the feature that really shapes the disease, is its growth rate. It's possibly the slowest growing human pathogen we know.
How slow are we talking?
Its doubling time is estimated at around 18 days.
18 days, not minutes or hours.
Days. Compare that to something like E. coli, which can double in maybe 20 minutes. Key whipplei is moving at a glacial pace, and that incredibly slow growth. It helps explain why Whipple's is so chronic, why symptoms can creep up over years, even decades. It's like this slow-motion invasion. Plus, using genotyping, looking at variations in its DNA, scientists have found over 100 different genotypes so far.
Different strains, basically.
Kind of, yeah, genetic variations. But interestingly, all these different genotypes seem to cause pretty similar diseases. It's not like one strain causes gut issues and another causes brain issues. They all seem capable of the whole spectrum.
18 days. That's just wild. It makes you wonder about how common it really is. Is it actually rare, or are we just missing it because it's so slow and sneaky?
That's a fantastic question. And it gets right back to how PCR changed things. Whipple's is still considered rare, yes, but we're definitely recognizing it more now. The old estimates were maybe 1 to 3 cases per million people. But a more recent U.S. survey, it suggests closer to 10 cases per million. Still rare, but, significantly more common than we thought.
Okay.
And then you look at seroprevalence. How many people have antibodies, meaning they've been exposed at some point, not necessarily sick? The numbers skyrocket. Around 50% of Western Europeans and maybe 75% of people in rural Senegal show signs of exposure.
75%? That's huge.
It is. And that higher prevalence in places like rural Senegal might be linked to differences in sanitation. Big clue there about how it spreads. And interestingly, humans are the only known host. We haven't found it naturally occurring in animals. Demographically, most studies show it's more common in males, more common in Caucasians, and the risk generally goes up with age.
So if humans are the only host, how is it getting around? Especially with those really high exposure rates in some areas, is there some hidden source, like in the environment?
That's the puzzle. To date, no clear animal or environmental reservoir has been pinned down, which makes figuring out transmission tricky. But we do have some really important clues. Its DNA has been found by PCR in sewage water and in human feces.
Ah, the sewage connection again?
Right. And we know, for instance, that workers who have direct exposure to sewage, they're much more likely to be asymptomatically colonized, carrying the bug without being sick compared to others. That strongly suggests fecal-oral spread. And look at families. Fecal PCR detection rates can be as high as 38% among family members of carriers or patients.
Wow. So spreading within households.
It certainly supports that idea, maybe oral-oral or fecal-oral spread, though you can't entirely rule out a shared environmental exposure for those families either. And then there's the finding of acute T. whipplei pneumonia in kids. That raises the possibility of, well, maybe even droplet or airborne transmission.
So multiple possible routes. Still a bit mysterious.
Exactly. It seems like there might be several ways people get exposed, and we're still trying to piece that whole picture together. Makes it even more elusive.
Fascinating. Okay, so loads of people are exposed. Quite a few carry it asymptomatically. But only this tiny fraction, less than 0.01% of those exposed, actually get the chronic disease. That brings us right to that complex dance. Host versus pathogen. Why do some get sick and others just don't? What's happening with the immune system?
That is the critical question, really. It looks like a complex interplay. It seems like both a reduced specific immune response from the host and the pathogen itself actively messing with, sort of dialing down, the host's inflammatory response are likely involved in letting chronic infection take hold.
So the body doesn't fight hard enough, and the bug actively helps suppress the fight.
Pretty much. For most people, their immune system probably clears it or keeps it dormant. But in those who get sick, it's like their immune system isn't firing on all cylinders against this specific bug, and T. whipplei is actively manipulating that response to create a safe space for itself. We've even found some genetic factors that seem to increase risk. Certain variations in our HLA system, that's part of how our immune cells recognize threats, specifically alleles DRB113 and DQB106, are linked to higher risk. These particular HLAs tend to push the immune system towards making antibodies, rather than the cell-killing response that's usually better for intracellular bugs like T. whipplei.
Okay, so a genetic nudge in the wrong direction.
Kind of. But importantly, only a minority of patients actually have these specific HLA types. So that tells us other host factors must be involved too. It's not just one gene. And there's a really interesting recent finding about a gene called IRF4. It's a key player in the immune response. They found a family where several members had Whipple's, and they all had a mutation, essentially giving them only one working copy of this IRF4 gene.
Like a specific inherited susceptibility.
Exactly. It looked like an autosomal dominant trait in that family, but with incomplete penetrance, meaning not everyone with the mutation got sick.
Yeah.
It just underlines how complex susceptibility is. It's really just one thing.
So it's not just about having the bug, it's about having this specific, maybe unfortunate set of immune system quirks that lets it persist. Can you get more specific about those immune problems? What does it look like when the immune system isn't fighting right?
Sure. Using techniques like flow cytometry to analyze immune cells, studies show that Whipple's patients have distinct abnormalities in their B cell subsets. Those are the antibody factories compared to healthy people. But more broadly, the chronic infection is tied to a specific pattern of immune dysfunction. We see an impaired Th1 response.
Th1, those are the cells crucial for intracellular invaders, right?
Exactly. They're like the generals directing the fight inside cells. If that response is weak, the bacteria gets a foothold. At the same time, there's increased production of anti-inflammatory cytokines.
So the body's sending signals to calm down the fight.
Precisely, which is the opposite of what you want here. We also see more activity from regulatory T cells in the immune system's peacekeepers. They suppress immune responses, and in Whipple's, they seem overactive, further hindering the attack. And here's a really critical part. The macrophages, the cleanup crew cells, they undergo something called M2 polarization. Meaning, instead of being aggressive bacteria killers, these M2 macrophages have reduced antimicrobial activity. They have trouble fusing their internal stomach, the phagosome, with the acid bath, the lysosome needed to digest the bacteria.
So the macrophage becomes a hiding place.
Exactly. It becomes a safe haven instead of a killer. There's also increased cell death, apoptosis, in these macrophages, and the body just doesn't develop enough T cells specifically trained to fight T. whipplei. This whole combination basically creates an environment where the bacterium can just hang out and multiply without much trouble. And a critical implication here, therapies that blunt that cell-mediated immunity, things like steroids or anti-TNF agents used for autoimmune diseases, they can actually accelerate the progression of Whipple's.
Wow, that's a huge clinical point.
It is. And this impaired immunity might also explain why some people become chronic carriers. Their immune system can't fully clear it, but it's not totally overwhelmed either.
That's a sobering thought, how treatments for other things could make this worse. So, given these immune issues and how the bug hides inside cells, what does it actually look like in the tissues? What are the pathologic hallmarks?
Right. Under the microscope, the classic finding, the most common one, is seeing tissue infiltrated with lots of these large, foamy macrophages. And inside these macrophages, you see those distinctive PAS-positive inclusions, those little pink-red granules we mentioned. That's the ingested bacteria. And critically, they are resistant to diastase enzyme. That helps distinguish them from other things like glycogen that might also stain pink with PAS.
Okay, so foamy macrophages full of PAS-positive stuff. What about in the gut specifically?
In the gastrointestinal tract, where it was first described, you see changes as the disease progresses. There's villus atrophy. The finger-like projections in the small intestine flatten out, which messes up nutrient absorption.
Hence the diarrhea and weight loss.
Exactly. You also see lymphangioectasia, dilated lymphatic vessels in the intestine. And crypt hyperplasia, more cells being made in the base of the intestinal glands. Plus apoptosis, or cell death, of the surface cells. All these changes contribute to that chronic diarrhea due to less absorption and more leaking of water and electrolytes. And sometimes, interestingly, you might see non-caseating granulomas, little clusters of immune cells in lymphatic tissue or the liver.
Granulomas, like in sarcoidosis.
Precisely. It can mimic sarcoid or even granulomatous vasculitis. Again, highlighting how it can masquerade as other conditions, making the pathologist's job really tough without that clinical suspicion.
Okay, we've covered the classic chronic infection, but you mentioned asymptomatic carriers and acute infections earlier. Let's touch on that silent side first. How common is just carrying T. whipplei without symptoms?
Yeah, asymptomatic carriage is a really significant part of the story. PCR studies routinely find T. whipplei DNA in stool, saliva, sometimes duodenal tissue, even rarely blood, in people with absolutely zero symptoms. The rates vary, but in Western Europe, maybe 1.11% carried in their stool, while saliva carriage is lower, maybe 0.2%, and usually only seen if they also have it in their stool. But rates are much higher in certain groups. People exposed to sewage, wastewater workers, maybe 12-26% carriage, and kids in tropical Africa and Asia, rates can be incredibly high, 20-48%.
Wow, nearly half in some groups.
Yeah, it points strongly to environment and hygiene. and it can persist. There's a documented case of a sewer worker carrying the exact same strain for 7 years without getting sick. But the crucial thing is, moving from being a carrier to developing chronic disease is uncommon. Most people exposed seem to either clear it or keep it dormant. And the bacterial load, the amount of bacteria detected, is usually much lower in carriers compared to people with active disease. That's another key difference.
Huge difference. So if chronic disease is rare, but carriage is common, what about acute infections? Maybe like a quick bout of illness that goes away. Are those happening more often than we think?
The evidence is mounting that, yes, acute encounters with T. whipplei might be much more common than we appreciate. Kind of like that first skirmish the body usually wins. For example, it's been implicated as a cause of acute gastroenteritis stomach flu in children. And in that study in rural Senegal, they found T. whipplei DNA in the blood of almost 5% of people with fever, mostly kids under 15, compared to almost none in healthy controls there.
Significant finding.
Very. Plus, it's also been linked to acute pneumonia. So putting it together, it suggests that when you first acquire T. whipplei, it might cause a short-lived symptomatic lung infection, or gut infection, or maybe just a fever. These acute episodes are probably often missed or just called a virus because they look like so many common things, but they might be happening way more often than the classic chronic Whipples we usually focus on.
Okay, now let's get into the really interesting part. The classic Whipple's disease. The one originally recognized, often hitting the duodenum or jejunum. Walk us through that long, slow progression. It doesn't just pop up, right? Sounds like a slow burn.
Definitely not overnight.
Hmm.
Classic Whipple's progression is notoriously slow, insidious, often taking years, even decades, to fully unfold. And it usually happens in phases, which can be really misleading. The first phase, often long before any gut symptoms start, is usually dominated by rheumatologic issues.
Joint pain.
Yeah, intermittent, often symmetrical joint pain affecting joints on both sides of the body, sometimes chronic, but rarely really destructive, like severe rheumatoid arthritis. We call it oligo or polyarthralgias or seronegative arthritis, because those standard rheumatoid blood tests are usually negative. Knees, wrists, ankles, the small joints in the hands, those are common targets. Less often you might see inflammation of the spine, sacroiliac joints, discs, tendons, bursae, even rarely infection around a prosthetic hip.
And it's not just pain.
Often accompanied by things like intermittent fever, muscle aches, sometimes even skin nodules. But because those standard RA tests are negative, this stage gets misdiagnosed all the time, confused with all sorts of other rheumatologic conditions. And this period of misdiagnosis, this rheumatologic phase, can last, on average, 6 to 8 years before the GI symptoms even start.
6 to 8 years. That's incredible. It's just hiding in plain sight as arthritis.
It's a true stealth attack.
And you mentioned the danger earlier, treating this presumed arthritis with immunosuppressants.
Exactly. That's a critical danger point. Giving immunosuppressants like steroids or anti-TNF drugs, which are common for inflammatory arthritis, can tragically accelerate the underlying Whipple's infection because you're suppressing the very immune response, trying, however weakly, to hold it back.
So screening might be important before starting those drugs in some cases.
Absolutely. Depending on the whole clinical picture, screening for Whipples before starting potent immunosuppressants might be warranted. And conversely, here's a clue. If a patient with this kind of joint pain gets antibiotics for something totally unrelated, like a UTI, and their joint pain unexpectedly gets better, that should ring alarm bells for Whipples. Antibiotics wouldn't help typical inflammatory arthritis.
Good clinical pearl. Okay, so after potentially years of joint issues, the classic GI symptoms finally kick in. What does that look like?
Right. Eventually, in most classic cases, the GI phase begins. The hallmark symptoms are persistent, often really bad diarrhea, almost always with significant, often unexplained weight loss. Frequently, there's also a chronic low-grade fever and abdominal pain mixed in. Less commonly, you might see things like occult GI bleeding, hidden blood loss in the stool, various vitamin deficiencies from malabsorption, and enlarged liver and spleen or hepatosplenomegaly in about 10–15%, and fluid buildup in the abdomen, ascites in maybe 10%. Blood tests might show anemia, maybe hypereosinophilia, high eosinophil counts.
And imaging, what do scans show?
On an abdominal CT scan, the most common finding is enlarged lymph nodes in the mesentery, or retroperitoneum, basically, lymph nodes in the abdomen, which often makes doctors worry about lymphoma, cancer, again, potentially delaying the correct diagnosis.
So even the imaging can be misleading. What about looking inside with an endoscope?
Endoscopy can provide really crucial clues. If the doctor sees a pale, yellow, or kind of shaggy-looking lining in the duodenum, maybe with redness or ulcers, especially beyond the very first part, that's highly suggestive of Whipples. Classic descriptions mention thickened granular mucosa, sometimes with these distinct white spots from dilated lymphatic vessels, things experienced endoscopists might recognize. If the initial scope and biopsies aren't diagnostic, sometimes a video capsule study swallowing a tiny camera can help find lesions further down the small bowel for later biopsy. And just to complicate things, sometimes patients might also have a co-infection, like Giardia, or their symptoms get confused with Crohn's or celiac disease. It's a master mimic, even in the gut.
What's just so fascinating, though, is that it's not just a gut disease. It's truly systemic. You said it can hit almost any organ. That must make diagnosis an absolute nightmare. Can you detail that range of involvement?
It really can. And yes, that multi-organ potential is what makes it such a diagnostic chameleon. Beyond the joints and the gut, it truly can pop up almost anywhere with different frequencies, different combinations, which is why you have to keep it on the radar for any chronic, unexplained multi-system illness. It forces you to connect dots that seem unrelated.
Okay, let's break down some key areas. Neurologic disease sounds particularly scary.
It is common and serious. Affects somewhere between 6% and 63% of patients, defined by finding the bug's DNA in the cerebrospinal fluid, CSF. About half of classic Whipple's patients eventually get some CNS involvement, and here's the kicker. Many are asymptomatic initially, no obvious neurosigns.
But if it is symptomatic,
It usually means a poorer prognosis, unfortunately. The common things are subtle cognitive changes, memory issues slowly worsening towards dementia, personality changes, mood swings, issues related to the hypothalamus like excessive thirst and urination, or severe sleep problems. Problems with eye movements called supranuclear ophthalmoplegia, difficulty looking up or down. Also things like nystagmus, jerky eye movements, or inflammation of the optic nerve.
are there any really specific neurological signs? Like pathognomonic ones?
Yes, there's one highly suggestive, almost unique sign. Oculomasticatory or oculofacial myarrhythmia. These are specific rhythmic movements of the jaw or face muscles synchronized with eye movements. If you see that, Whipple's should be right at the top of your list. It's very rare otherwise.
Oh.
Beyond that, it's a huge range. Seizures, ataxia, balance problems, meningitis, encephalitis, inflammation in specific brain areas like the rhombencephalon or limbic system, hydrocephalus, fluid on the brain, myelopathy, spinal cord issues, myoclonus, muscle jerks, chorea, writhing movements, even peripheral neuropathy. Sadly, neurological damage is common, and the mortality risk is significant with CNS disease.
And imaging. Does an MRI always show it?
Not necessarily. The MRI can be normal, even with significant disease. Another way it hides. When lesions are seen, they can be single or multiple, usually bright on T2 and flare sequences, might enhance with contrast. Pretty much any part of the brain can be involved. Lesions can look like nodules, infiltrates, even tumors. Common spots are the temporal lobe, midbrain, hypothalamus, thalamus. PET scans might show increased activity. And CSF analysis, also tricky, can be normal. If abnormal, usually shows increased white cells, mostly lymphocytes, and high protein, sometimes rarely low glucose.
Just a neurological minefield. Okay, what about the heart? How does it hit the cardiac system?
Cardiac disease is definitely being recognized more now. Effects may be 17% to 55%. Endocarditis infection of the heart valves is especially prominent, making up 85% of cardiac cases in males. And it's a significant cause of culture-negative endocarditis, where you suspect valve infection, but standard cultures don't grow anything. Whipple's accounts for maybe 2.6% to 6.3% of those cases.
So another place it hides from standard tests.
Exactly. It can lead to complications like congestive heart failure in 40%, blood clots traveling, embolic events, arrhythmias, weakened arteries, mycotic aneurysms, rarely low blood pressure. The diagnostic challenge, fever is often absent, and the usual due criteria for endocarditis, rarely met.
Makes it really hard to diagnose then.
Very. Echocardiograms, heart ultrasounds find vegetations on the valves in maybe 50–75% of cases. Any valve can be involved, but aortic and mitral are most common. Often there's pre-existing valve damage too. Less often, you can get constrictive pericarditis inflammation thickening the sac around the heart. But often, sadly, the diagnosis of cardiac Whipple's isn't made until the patient needs valve surgery because the symptoms are so nonspecific.
Gut, brain, heart. It's relentless. What about the lungs and the lymphatic system?
Pulmonary disease hits 10–50%. Can show up as interstitial lung disease, scarring, nodules, infiltrates, fluid around the lungs, pleural effusion. It's even been linked to pulmonary hypertension. But here's a nuance. Finding whipplei DNA in lung fluid, like from a BL wash, especially in someone asymptomatic or with other lung issues like HIV, its significance isn't always clear.
Meaning finding the DNA doesn't automatically mean Whipple's is causing a lung problem.
Right. Caution is needed. It seems the bacteria can be present in the airways, particularly in HIV patients, without necessarily causing inflammation or reduced lung function in that context. So you need more evidence than just the PCR result from DALF alone for a diagnosis of isolated lung whipples. Lymphatic disease is common too, 10–55%, often alongside the gut disease, those enlarged abdominal lymph nodes. You can also get enlarged nodes in the chest, mediastinal, with lung involvement. Peripheral nodes, like in the neck or armpit, are less common.
Okay, and another spots, eyes,
Yeah.
skin.
Yep. Ocular disease, the non-neuro kind, affects 5–10%. Most common is uveitis inflammation inside the eye. Presents as vision changes, floaters, can affect the front, middle, or back of the eye. And a huge warning here, treating presumed uveitis with just steroids can actually worsen the Whipple's uveitis and, even worse, unmask infection elsewhere in the body.
Oh.
Yeah. Even steroids after eye surgery can trigger an infection if subclinical Whipple's was already there. Other eye issues include keratitis, cornea inflammation, crystalline deposits in the cornea, optic nerve inflammation, and again, often misdiagnosed first as sarcoid or Behçet's disease.
And the skin. You mentioned that can offer clues.
Dermatologic signs in 5–30%. A key suggestive sign is skin hyperpigmentation melanoderma, especially in sun-exposed areas, without adrenal problems, like a tan that doesn't make sense.
Interesting.
Other skin things can include flat red spots, purpura, small bruises not due to low platelets, nodules under the skin, thickened skin, hyperkeratosis, and beyond those, well, under miscellaneous sites, it's been found in the thyroid, kidneys, testes, epididymis, gallbladder, muscles, even bone marrow.
So taking that step back again, the picture is just, wow. Almost any organ can be involved in classic Whipples, different frequencies, different combinations, countless symptoms. It really is the ultimate masquerader.
Exactly. That's the takeaway. Despite being rare, you have to consider Whipples in any chronic, unexplained multi-system process. That specific combination, joint problems, gut issues, weight loss, especially with weird neuro or cardiac stuff thrown in, that really warrants a high index of suspicion. It forces that cross-specialty thinking.
Incredible how wide it spreads. Now, you mentioned isolated infection earlier. Does that mean it can show up without the classic gut symptoms, like just in the heart or brain?
Yes, and that's a really important evolution in how we understand it. Isolated infection means finding T. whipplei infection without obvious intestinal symptoms like diarrhea or major weight loss. Though it's a bit of a misnomer. Even without symptoms, a small bowel biopsy might still be PAS positive or more likely PCR positive. The gut might be involved silently, and it's rarely truly isolated to just one spot outside the gut. Often, multiple non-intestinal sites are involved together, even if the gut seems quiet symptomatically. Plus, even if it starts seemingly isolated, intestinal disease can still develop later on, sometimes years later.
So which sites are common for these isolated presentations?
Pretty much the same ones that get hit in classic Whipples. Endocarditis, neurologic disease, uveitis, joint problems, lung involvement. The symptoms in those organs are similar to what we described before. And with better PCR diagnostics now, we're probably going to diagnose these non-intestinal presentations, like endocarditis being a prime example, much more often. We're seeing more of the iceberg now, not just the classic gut-centric tip.
Makes total sense. Okay, so diagnosis is made, treatment starts. Is it smooth sailing? Or are there bumps like relapse reinfection or this IRC thing, immune reconstitution inflammatory syndrome? Sounds like this bug doesn't give up easy.
No, it certainly doesn't. It's not always a straightforward cure, and you're right, T. whipplei can be incredibly persistent. There are definite complexities even after seemingly successful treatment. First, you've got reinfection or relapse. Thinking is, if someone has that underlying immune susceptibility that let them get chronic Whipples in the first place, they might remain at risk.
Risk of getting it again.
Exactly. Either from ongoing exposure, like a sewer worker, or maybe contact with family members who are carriers. There's even a documented case where someone relapsed with a different genotype of T. whipplei, strongly suggesting reinfection is possible. And these relapses or reinfections, they can happen years, even decades, after the initial treatment seemed to work. It demands long-term vigilance.
Decades later. Wow. And what about iris?
Right, immune reconstitution inflammatory syndrome. We see this with HIV treatment, TB treatment too. It happens in up to 17% of Whipple's patients during treatment. It's this paradoxical worsening, not because the infection's back, but because the immune system is finally recovering and mounts this massive, sometimes over-the-top inflammatory response to leftover bacterial bits.
What triggers it?
Having had prior immunosuppressive therapy seems to increase the risk. And in iris, the inflammation comes back after the patient initially improved on antibiotics, and crucially, after PCR tests for T. whipplei become negative. The bug is gone, but the inflammation flares. Symptoms can include fever, arthritis coming back, new skin lesions, nodules, pleuritis, uveitis, eye inflammation. Tragically, some cases have even been fatal. It's a really delicate balancing act during recovery.
Given all these challenges, the mimicry, the relapse potential, what are the absolute must-do steps for diagnosis? It sounds like just thinking of Whipple's is maybe the biggest step.
You absolutely nailed it. The most critical steps. 1. Considering T. whipplei infection in your list of possibilities. 2. Making sure the right tests get done. Without that initial suspicion, without thinking, could this be Whipple's, the diagnosis will likely just be missed, period. It demands that detective work, that high index of suspicion.
Okay, so step one is suspicion. Where do you go next? Is serology checking blood for antibodies helpful for active infection? Sadly, no. Serology is of very little value for diagnosing active Whipple's. Patients who are actively infected usually have a pretty poor antibody response, e.g. MIG, to T. whipplei. So a positive antibody test probably just means they were exposed sometime in the past and cleared it. It doesn't reliably tell you if they have active disease now. It's frustratingly unhelpful for diagnosis.
Okay, scratch serology. So where should clinicians look for the bug? The symptoms will guide that partly, but what's the best specimen strategy? Right, the symptoms point you, but you also need to know where it likes to hide. If there are GI symptoms, definitely get post-bulbar duodenal biopsies during endoscopy. And critically, remember the gut lining might look normal. Biopsy anyway if you suspect Whipple's. Don't rely on visual appearance alone. As a general principle, you get a better diagnostic, yield better chance of finding it from tissue samples compared to body fluids. Interestingly, even a biopsy of normal-looking skin might pick up T. whipplei and classic Whipple's. Could be a minimally invasive way in some cases. And here's a really crucial one, given how common CNS involvement and relapse are. It's generally prudent to collect cerebrospinal fluid, CSF, for testing, even if the patient has no neurological symptoms.
Even with no symptoms, why?
But because asymptomatic CNS disease is common, the CNS is the most frequent relapse site, and knowing if it's in the CSF, even silently, can dramatically change your treatment plan. The drugs, the duration. It's proactive diagnosis guiding better therapy.
Got it. Okay, let's talk traditional methods, histology, microscopy. Before PCR, this was it, right?
Pretty much. They were the backbone, and still have a role. The original diagnosis of classic Whipple's relied on seeing those characteristic findings in intestinal biopsies, specifically infiltration of the lamina propria, with those foamy macrophages packed with the PAS-positive diastase-resistant inclusions, those pink granules. But histology alone isn't perfectly sensitive. It can miss cases. And PAS staining isn't specific. Other bugs like Mycobacteria, Rhodococcus, Bacillus corneobacterium, histoplasma can also stain PAS positive.
You need other stains to differentiate.
Right. You use Zeal-Nielsen for Mycobacteria, for example. T. whipplei also stains with silver stain, weakly with brown bran or acridine orange. It doesn't stain with calcofluor. These patterns help. You can also stain other tissues or fluids, like from the eye, for these PAS-positive macrophages. And remember that warning. Prior anti-TNF therapy can actually reduce the sensitivity of finding these PAS inclusions. It can hide the evidence.
Complicating things further.
Right.
What about other microscopic techniques?
Electron microscopy can show the specific trilaminar cell wall structure of T. whipplei. Very specific, but not widely available. Immunohistochemistry, IHC, using antibodies against the bacteria, offers better sensitivity and specificity than PAS, and can even be done on old archived tissue blocks. And SCH fluorescence in situ hybridization is another tool, lighting up the bacterial DNA in tissue samples, a complementary approach.
So traditional methods are useful but have limits, potential confounders, which brings us back to the game changer, PCR. How has that revolutionized finding this bug?
It really has been revolutionary. PCR-based diagnostics massively increased both sensitivity finding it when it's there and specificity making sure it is T. whipplei. You can apply PCR to affected tissues. It works better on fresh or frozen tissue than formalin fixed. By the way, to confirm or support histology findings by detecting that unique genetic signature. But the huge advantage is its use on body fluids. CSF, eye fluid, joint fluid, pericardial fluid, pleural fluid, lung washings, BALF, blood, even urine. It makes diagnosis much less invasive sometimes.
Allows you to track it across the body.
Exactly. But, like any test, you have to interpret PCR carefully. False positives can happen from contamination. It's super sensitive. False negatives can happen too, maybe low bacterial load, poor sample, problems with DNA extraction, or just different labs having slightly different assay performance. So you always have to consider the pre-test probability. How likely did you think Whipple's was before the test? A negative PCR doesn't absolutely rule it out if everything else points strongly towards it. Clinical judgment is still key.
And you mentioned urine PCR specifically. That sounded promising.
Yes, urine PCR looks really promising for non-invasive diagnosis, especially distinguishing active disease from carriage. One study found a positive in 75% of active cases before treatment versus zero controls, including zero carriers who were positive by feces PCR.
So urine PCR for active disease, feces PCR more for carriage.
That seems to be the pattern. A positive feces PCR usually needs confirmation from tissue or another body fluid to confirm active disease, not just colonization. But urine PCR might be a direct window into active infection. Needs more study, but very promising.
Very cool. What about actually growing the bug? Is culture useful for diagnosis? And can imaging help guide where to biopsy?
Well, whipplei can be cultured from various sites, blood, CSF, valves, tissue. But it's just not practical for clinical diagnosis.
Why not?
Because it grows so slowly, it can take months to get a positive culture result. You can't wait that long to start treatment for a potentially fatal infection. So culture is mainly a research tool. As for imaging guidance, yes, FDG PTT scans can be helpful. Areas affected by Whipples often show increased metabolic activity, lighting up on the PT scan. So seeing a hotspot on PTT could guide you to biopsy that specific area, increasing the chances of getting a diagnostic sample for histology or PCR. It helps target the investigation.
Okay, so we've covered finding the elusive beast. Now, treatment. This sounds like a tough nut to crack, given it hides in cells and grows so slowly. What are the main challenges?
You're right, it's a challenge. Treatment data is still evolving, and we don't have one single perfect regimen or duration nailed down for every situation, especially for tricky spots like the CNS or heart valves. But the good news is, the right treatment usually leads to a rapid, sometimes truly remarkable clinical improvement. Especially with CNS symptoms, patients can get dramatically better. The hard part is eradication. It takes prolonged treatment, and keeping it gone, achieving a durable cure, is tough because of that risk of relapse or reinfection due to the underlying host susceptibility. It's a long-term battle.
Makes sense. What about older treatments? What did we learn from the ones that didn't work so well?
Yeah, historically, some regimens just didn't cut it. Relapse rates, especially CNS relapse, were unacceptably high with just oral tetracycline or TMP-SMX alone. And now we know why, thanks to molecular data. The TMP part of TMP-SMX is not actually active against T-whipplei. The bug lacks the enzyme TMP targets.
So we were using a drug that didn't even work.
Pretty much, for the TMP component. Plus, resistance can develop to the SMX part and related drugs like sulfadiazine. Understanding the bug's biology, explain those past failures, and stressed why we need drugs that do hit the target effectively.
Right. So knowing that, how have modern treatments evolved? What's the best approach now to really knock this thing out?
Well, what's fascinating is how we've combined that biological understanding with clinical experience. A key randomized trial showed really good results with a two-phase approach. First, an intensive IV phase, either ceftriaxone, 2 gram daily, or meropenem, 1 gram every 8 hours for 2 weeks. Powerful 4E antibiotics to start, followed by oral TMP-SMX, the standard double-strength dose, twice daily for a whole year. That regimen had excellent efficacy in the trial.
A year of oral meds after the aside.
Yep. There was only one failure in that trial, an asymptomatic CNS infection that persisted, but that patient was later cured with oral minocycline and chloroquine. Another trial showed similar results with just 3 months of oral TMP-SMX after the IV ceftriaxone. But a potential issue with those trials, the IV doses used, and maybe the duration, probably weren't optimal for hitting the CNS hard enough. Penetrating the blood-brain barrier is tough.
So maybe needed higher doses for brain involvement.
Potentially.
Yeah.
And contrasting that, a small retrospective study suggested better outcomes with a different oral combo. Doxycycline, 400 milligrams twice daily, plus hydroxychloroquine, 200 milligrams 3 times daily.
Hydroxychloroquine, why add that?
The idea is pretty neat. Lab studies suggest hydroxychloroquine raises the pH inside those macrophage compartments where T-whipplei hides. Making it less acidic might boost the antibiotics activity right where the bug lives.
Clever. So what's the current recommendation, especially if the brain might be involved?
Until we get more large-scale trial data, the prudent approach, especially if there's any CNS involvement, symptomatic or asymptomatic, which is common, is this. Start with CNS-optimized IV doses, ceftriaxone 2 grams every 12 hours, or meropenem 2 grams every 8 hours for 2 to 4 weeks. Really flood the system, ensure good brain penetration. Then follow that with oral therapy, preferably doxycycline or minocycline plus hydroxychloroquine, for at least 1 year if the patient tolerates it.
So favoring doxycycline hydroxychloroquine over TMP-SMX for the oral phase now.
There's a growing caution around TMP-SMX for the oral phase. While it's been used successfully, there have been enough reports of relapse or reinfection with it to suggest caution, especially if the infection is in critical spots like the CNS or the heart. The doxy-HCQ combo seems potentially more reliable for those tough cases based on current thinking. It's about tailoring the attack.
That makes sense. Hit hard, hit long, and use the best tools for the location. Can PCR help guide how long to treat? Like, keep treating until the PCR is negative. And what about specific sites, like endocarditis?
That's the logical question, right? We don't have definitive trial data saying treat until PCR negative, but clinically it seems very reasonable. If you keep detecting T. whipplei by PCR, especially in the CSF, or maybe even urine, that should argue strongly for continuing therapy, maybe even switching regimens if the patient isn't improving clinically. It's a signal the bug is still active. For endocarditis, timely diagnosis is key because you might cure it with medical therapy alone, avoiding surgery. But surgery might still be needed for bad valve damage or abscesses. European guidelines suggest long treatment, oral doxy plus hydroxychloroquine for at least 18 months, or an alternative initial IV combo followed by a year of doxy-HTQ. It underscores how serious and prolonged cardiac treatment is.
18 months or more. Wow. What about other isolated infections or specific issues?
Data is even more limited there. For uveitis, there are reports of success with TMP-SMX, maybe with rifampin, but tetracycline alone led to relapse. Combination therapy seems key. Whether injecting drugs directly into the eye helps is unclear. For really refractory, stubborn cases, there's that one report where adding interferon gamma to antibiotics finally cleared a chronic relapsing infection. Suggests maybe immune modulation could play a role in super tough cases or suspected resistance, and infections involving foreign bodies, like joint replacements. Almost no data. One report of success treating a prosthetic hip infection medically, but follow-up was short. Very much uncharted territory.
So treatment is long, complex, tailored, and comes with potential complications like relapse. What other complications arise, and what are the long-term strategies given that risk?
Well, early on, within 24 hours of starting antibiotics, patients might get a Jerisch-Herxheimer reaction, temporary worsening as bacteria die off. Usually mild, resolves quickly, but good to anticipate. Then there's IRIS, that immune reconstitution syndrome we talked about. Managing that might involve adding steroids to calm the inflammation. Thalidomide has even been used if steroids aren't enough. And the big long-term question, because of that inherent risk of relapse or reinfection, some experts advocate for lifelong suppressive therapy with doxycycline after the initial year or more of intensive treatment.
Lifelong antibiotics.
Potentially. Just a low dose to keep any lingering bugs suppressed. But it's important to stress we lack strong trial data to definitively prove this lifelong approach is necessary or beneficial for everyone. It's still debated. But regardless of the exact regimen or duration, what is absolutely crucial for success is ensuring the patient sticks to the long treatment plan, compliance, and gets close long-term follow-up. Because relapse or reinfection can happen years later. Lifelong vigilance is key to maximizing the chances of a good outcome, turning this potentially devastating illness into something manageable.
What an absolutely incredible journey today. From those first baffling symptoms of Whipple's, through that painstaking century of discovery unmasking Tropheryma whipplei, its complex chameleon-like spread through the body, and finally to these evolving, life-saving treatments. It just perfectly highlights the diagnostic maze, the sheer breadth of how it can look, and why getting that diagnosis right and early is just so incredibly critical for a disease that loves to hide.
It really does. And the key takeaways for you, the listener, as you master this complex topic, are really profound. PCR truly changed everything, revealing how widespread and diverse this disease is. It's clear now, you have to consider Whipple's in anyone with a chronic multi-system illness, especially that combo of joint and gut issues with weight loss, maybe weird neuro or cardiac signs too. Getting the diagnosis can be a long road, but the impact of the right, prolonged therapy tailored to where the infection is, it's literally life-saving. Understanding Whipple's means understanding how to connect those seemingly unrelated dots.
So, what does all this mean for you listening? Whether you're just curious, a healthcare professional, or aiming for that elite understanding. Think about it. A disease hiding in plain sight for years, looking like arthritis, dementia, heart failure, you name it. What does this bug's ability to dodge our immune system, its incredibly slow growth, tell us about the hidden battles maybe going on inside us, battles we don't even know about until years of subtle clues pile up? And with diagnostics always improving, like that potential urine PCR test, how many other diseases we currently think of as rare might actually be more common, just waiting for the right tech and the right index of suspicion to finally bring them out of the shadows?